Epitympanic spaces. The epitympanic space is a pneumatized portion of the temporal bone superior to the mesotympanum. Different authors studied the anatomy of the epitympanic compartments. Recently, Palva and Call described the anatomy of epitympanic diaphragm studying ventilation pathways of the epitympanium. Epitympanic diaphragm consists of three malleal ligamental folds, anterior, lateral, and posterior, the posterior incudal ligamental fold, and two purely membranous folds, the tensor fold and the lateral incudomalleal fold, together with the malleus and incus. From this anatomical point of view, it is possible to classify the epitympanium in two different compartments: a larger and posterior one, posterior epitympanic space, PES, and a smaller and anterior compartment, anterior epitympanic space, AES. Body and short process of the incus together with head of the malleus occupy the majority of posterior epitympanic space. The lateral portion of posterior epitympanium is narrower, and it is divided in two further portions by the lateral incudomalleal fold. They are separated and arranged one above the other. The superior and inferior lateral attic. Inferior lateral attic is bounded superiorly by the lateral incudomalleal fold, and it is located between the more declive portion of short process and body of the incus medially and the medial aspect of the scutum laterally. This anatomical area is therefore in a lower position to the epitympanic diaphragm and is in communication with the underlying mesotympanum. Mesotympanic region guarantees ventilation of the inferior lateral attic. In a more cranial position lies the superior lateral attic, whose inferior limit is represented by the incudomalleolar fold. This anatomical area together with the medial attic is the so-called superior attic or upper unit. Superior attic is in communication with the mesotympanum through the underlying tympanic isthmus, and posteriorly it is open to the adductus ad antrum. Its upper limit is tegmen tympani, while the lower one is given by the second portion, intratympanic, of the facial nerve, and laterally it is bounded by the lateral bony wall of the atticus. The whole superior attic is ventilated through the isthmus. Epitympanic compartments receive their aeration via the large tympanic isthmus between the medial part of the posterior incudal ligament and the tensor tendon. Palva et al. Observed that the aeration pathway from the eustachian tube leads directly to the mesotympanic and hypotympanic spaces, whereas the epitympanum is away from the direct air stream and is only aerated through the tympanic isthmus. The lower unit is a reduced compartment represented by the Prussic space. It is separated anatomically and physiologically from the upper unit by its vault, which is represented by the lateral malleal ligament fold, Fig. 6ac. This inferior epitympanic portion is ventilated in the majority of cases from the posterior pocket through mesotympanum, Fig. 8bc. For this reason, the two ventilatory trajectories of the epitympanic units are separated from each other. We strongly believe that this physiological concept is of extreme importance in transcannular endoscopic middle ear surgery. This is because restoration of ventilation pathways with unification of the upper and the lower unit through the creation of a large tympanic isthmus and an accessory route through the tensor fold is the basis of this surgery. Surgery must ensure ventilation to all parts of epitympanum. Posterior epitympanic space contains the incudomalleolar joint. This articulation is a crucial landmark also during the transcannal endoscopic approach. When the endoscopic surgeon has to deal with an epitympanic involvement of cholesteatoma, he needs to remove the scutum by drilling the lateral bone in the attic, discovering the body of the incus and the head of the malleus. Short process of the incus shows us the antrum's location, Fig. 9ab, and drilling the bone over the short process we can go directly to the antrum without any problem, Fig. 9cd. In this way we are able to endoscopically remove epitympanic pathologic tissue with antrum involvement. In some, the ossicular chain is not present into the epitympanic compartment, and thus we need other anatomical landmarks. In our experience, we use an anatomical triangle as a landmark in these complex cases, Fig. 10. The superior side of this triangle is tympanic tegmen, bony wall of the AES draws the anterior side, and the inferior side is the lateral semicircular canal wall. Tip of the triangle show us where is the antrum, and the surgeon can drill in a safety way until the antrum is visible, Fig. 10 CD. During transcanal approach we need to look for the second tract of the facial nerve in order to find the lateral semicircular canal. It usually lies superior and posterior to the facial nerve.